Women are getting reports saying, quote, your breast tissue is dense. So what does it mean? If you get that report, what does it mean? Your breast tissue is dense. Well, in many women, the breast is made mainly of fatty tissue, and if there's a tumor present, the fat, in contrast to the tumor, brings great highlight to that tumor, so it's easy to see. But there's a group of women, and about 40% of women who undergo mammography have dense breasts. It means there's more connective tissue and fibrous tissue in the breast than the other women, and that means it may be harder to read your mammogram. So it lowers the sensitivity of the mammogram if you have dense breasts. So many states now, from Hawaii to California and New York, New Jersey, women are receiving letters, and they're legally obligated to receive these letters by state law saying the breast tissue is dense. Now, how did this all start? Well, there's a woman named Nancy Capello, a 61-year-old Connecticut woman whose breast cancer had spread to her lymph nodes by the time it was diagnosed 10 years ago, even though she had normal mammograms every year. Her cancer was about an inch, was about 2.5 centimeters when it finally became palpable. Her doctors thought that it had been growing for 4 or 5 years, and she'd had all these mammograms saying she was okay. Well, now, if you have dense breasts, you're going to know about it. You're going to meet with your doctor and do things, maybe like getting 3D tomos of the breast, or MRIs of the breast, or ultrasounds of the breast, or a physician exam of the breast, or even all of those if necessary. So that's what dense breast means. We want each woman to have the best chance of never seeing the cancer again, and that's what dense breasts mean. Need more work, more diligence to evaluate each woman's breast. We had a woman come in this week, 80-year-old Hispanic woman who had newly diagnosed cancer of the esophagus. The esophagus is the tube from the mouth to the stomach. The cancer had spread to the liver. She was diagnosed a couple of weeks ago at a big hospital in Manhattan. She's already lost 30 pounds. A lot of people with esophageal cancer lose a lot of weight. She's gone down to 125 pounds. She can't eat solids. She can only eat liquids. We spoke to her about treatment options for her esophageal cancer. One is to stage her to know exactly where the cancer is, and then secondly, to offer treatment. Radiosurgery might be great for her because her cancer has spread, and she has symptoms, including this obstruction in her esophagus. So it's a nice way to shrink down the cancer in most people, works in the vast majority, and also for a metastatic esophageal cancer, it works to relieve pain, suffering, and actually shrink down the cancer in many of the patients. And while we're in the gastrointestinal tract, we saw a woman, pretty young woman, who had recurrent rectal cancer. She was treated at a big cancer hospital a year ago for recurrent rectal cancer. So a year ago, I met with her, talked about all the options, and she chose another way. She chose surgery at the big cancer hospital. She was seen at a variety of hospitals, and sad to say, the cancer came rip-roaring back only in one spot, only in the rectal area where it was originally, where it was operated once, and then again last year. Now it's back again in that same spot. So we spoke about radiosurgery. We got her staged up quickly. So we know the only active site by PET CT scan is the pelvic area, the rectal area. The tumor's about 8 centimeters, the size almost of a fist. So she is lined up to commence body radiosurgery. Should be 5 treatments. Beams are focused on the tumor area. Success rate is high. It's non-invasive. It's nothing like chemo. Chemo goes in by vein from head to toe. Surgery is invasive. Standard radiation is lots of treatment and involves surrounding tissues as well. whereas radiosurgery is usually few treatments, focused, with higher success rates because of radiobiologic principles that a few higher dose treatments work better than weeks and weeks of standard treatment. If you have questions about it, you should give us a call. You can call us during the week at 212-CHOICES, 212-CHOICES. I know many people are shy about calling the radio show, but certainly call during the week. So we take those calls. Obviously, best is to come in, sit down, and spend some time together to go over the details of the case, to learn more about what you have, where it's been, what are the symptoms, give you copies of the documents, repeat the staging to know where the cancer is today, if that's necessary. And then you're the president of the United States of your body. You decide, after hearing all the options, which direction you want to go. It's your body. You are the president of the United States of your body. Now, the president, as we know, doesn't always make the right decisions. So this is a man who came in, 60-year-old man with prostate cancer, was diagnosed in 2008 with a Gleason 8. So Gleason was a pathologist. He tried to tell us how aggressive cancers are. The higher the number, ranging from 2 to 10, the higher the number, the more aggressive the cancer. So a Gleason 8 is an aggressive cancer. This gentleman came to me in October last year with a PSA of 11 and declined therapy. He said he was going to do something else. Well, what did he do? He tried herbs, alternatives, vitamins, antioxidants, intensely. He made a big effort, spent a lot of money with all those herbs and antioxidants. And the result? Well, the result, his PSA was 11 then. Today it's more than 20. So the PSA has doubled. He's in big trouble. He's waited a long time. We know the death rate in the black male community from prostate cancer is twice that in the white. Why? Mainly because of waiting. We urge you, if you have cancer, to come in. We promise to see you within one business day. We'd rather work more than you suffer more. So for this gentleman, we're restaging him, making sure the cancer's still localized. Now he wants to be treated. Wow, he's on the edge. He's on the precipice. We need, I believe, to get treatment going soon. So his PSA went from 9 to 11 to 20 plus in just a short period of time, doubled in 6 months. So we wish him well. If you look at our data, and by the way, we have a prostate cancer booklet. If you look at the data, for example, for a group of men with PSA 20 to 50, people who have surgery versus us, our method is treating in the stereotactic frame and brachytherapy. 66% more men are cancer-free if they come to us than if they had radical surgery. So this is page 6 of our new prostate booklet. We have a new prostate booklet just came out. We're happy to send it to you at no charge. Just call us during the week, Monday through Friday, 9 to 5. We'll get your name, address, and telephone number. We'll put a package in the mail. You will see figure 7, page 6. If you have a PSA 20 to 50, there's a 66% better chance of being cancer-free with us than if you went to the chief of surgery at a big cancer hospital. And we know, if you look on page 14, the likelihood of sexual problems after surgery, whether it's open or robotic, is 97%. The likelihood of urinary problems after surgery, 80 to 86% with open and robotic surgery. So I know robotic is talked about like it's super-duper pooper scooper, but in fact the toxicity rates in a study from Harvard Medical School, this is figure 21, page 14 of our prostate cancer booklet, shows actually the complication rates with sexual complications and urinary complications are higher with robotic surgery. So if you want the best chance of being cancer-free, best chance of keeping sexual life, best chance of keeping urinary life, we know the answer. It's 212-CHOICES. Call Dr. Lederman, 212-CHOICES. Also, there's information about watchful waiting in the booklet, which we can talk about if someone calls, or better yet, just order the book, no charge, and read about it. So for this man, PSA 20, high Gleason score, we're restaging him, making sure he's a good candidate. We don't want to treat him if it's not going to help. We want the best chance to help him. We don't like to do things for no reason, and we're moving ahead. There's also seems to be an epidemic of skin cancers right now. We're treating one man with 4 skin cancers on his hand, on his left hand. He's coming from Connecticut because he didn't want to have Mohs, M-O-H-S, Mohs surgery, which is like salami slicing of the body. They keep on slicing until they don't see any more cancer cells, regardless of what the body looks like. So you can imagine when you have a salami, you start out with a big salami and then you end up with a small salami. Well, some people have a lot of their salami cut off with Mohs surgery. This man had 4 separate lesions of the hand. We're treating it. It's already going away on treatment. You can barely see it. We wish him well. We have another man with 4 lesions on the face, including one big one under the left eye, and that's melting away. It's incredible. So they come in, they have 4 separate lesions treated simultaneously. Tumor's going away. They're happy. Treatment takes about 15 minutes. They come in, get their treatment, and get back to their normal, healthy, good, fun life. And at the bottom of the hour, I want to talk just a minute about a 60-year-old black man, single, no children, who has a Gleason 7 PSA 5.9 prostate cancer. A patient came in. He wakes up twice a night to urinate. We offered medication to help his urination. His sex life was poor. He wants to have the best chance of being cured. If you look in our book, Gleason 7 Cancer, and I give you that reference for Gleason 7 Cancer, if you go to the hotshot surgeon in town, the likelihood of being cancer-free is 60%. Actually, there's data from Harvard Medical School and from University of Pennsylvania, which was published data a couple years ago as headlines in the paper. For Gleason 7, their success rate was 60%. This is page 11 of our booklet, figure 15. You can see the data from yours truly, Lederman, using the stereotactic frame and brachytherapy. We're at 90% for Gleason 7 cancer, or PSA 10 to 20. The best data, those 2 Ivy League institutions, was 60%. So it makes a difference where you get the treatment. It makes a difference what your treatment is. And I'd advise you very strongly to look at the data. I can tell you, we see a lot of sad people who see the data after they've had treatment elsewhere. So don't be sad. Look at the data first. Be smart. And talking about smart, we're going to hear from our sponsor for just a minute, and then we'll be right back. Thank you. Talk soon.
Here's Dr. Gil Lederman, New York's only Harvard-trained, triple-board-certified radiation cancer doctor. If chemosurgery or radiation isn't working or isn't tolerated, when cancer and its pain and symptoms aren't getting better, seek a fresh second opinion at Radiosurgery New York's Urgent Cancer Consultants for innovative, custom-tailored cancer treatment. See our experts within 1 business day because we know your time and your life are precious. Our goal is proper diagnosis and effective, non-invasive outpatient treatment. Decades of leadership, first in New York with brain radiosurgery, first in America with body radiosurgery for cancers of the brain, body, and prostate, all custom-tailored for you. Call 212-CHOICES, 212-CHOICES for a prompt appointment and free booklet DVD. Super convenient, 38th and Broadway, with most insurances, Medicare, Medicaid accepted. You're next at Radiosurgery New York. Just call 212-CHOICES, 212-CHOICES.
You know, cancer, it's not prejudice. It strikes everyone. We've seen the racists with the big C. We've seen humanitarians struck down with the big C. But there are remedies, even if you've already had different measures of treatment, like prior chemo, surgery, or radiation that didn't work. Now, I'm telling you, there's a guy out there who is clearly the best at this. First tryout or second tryout, that's Dr. Gil Lederman. My personal experience in 1991 is he came up with a remedy for